So we are talking about kind of tough decisions in the clinic, tough days, tough patients, maybe tough patient presentations or tough patient attitudes, because you get that from time to time as well. Kind of talking about all the different things that we see in clinic, and just kind of break down what Christian and I, what we do, what we rely on, and maybe just share some experiences and just kind of talk through it a little bit, some interesting cases. In the last week or two, how many tough decisions or tough things that you had to really think through or, you know, put some effort towards to get through in the clinic?
Well, to be clear, for anyone listening, we are not emergency doctors. So like tough is
Yeah,
relative. These
tough
aren't
is relative.
these are
Yeah,
typically not life or death decisions. I've only had to make one or two of those calls. I'm like, this person might actually need emergency help.
yeah,
I know you had one not too long ago. Um, but to answer your question, probably like 5 or 10 per week. It
yeah,
really isn't that bad out of the 15 or so people I see per day. Most of the time, people are pretty chill. Things aren't too crazy, but you will get those people who usually they're just frustrated. They've been through a lot. They're in pain, of course.
hmm,
They're already going to be pretty amped up. But then you tack on waiting 2 to 4 weeks to get in to see you. They're getting the runaround from their doctor, or at least from their perspective, they are. And they're just a tough personality. They tired of being in pain and they want help. They want answers. And I get that.
yeah,
You have to have those moments where you sit down and talk to them and hear them out like a real person would, and just listen to them. Be like, look, this is what I think is going on. This is how we're trying to help manage this case for you. And just lay it out plainly for them, which I always find works the best for calming folks down, whether they're angry
yeah,
or they're just really stressed out and anxious about what's going on.
right. Just to build off that point, I think just talking to them like they're another adult human, you know, I think sometimes, unfortunately, patients can get talked down to at times, or they feel like they're getting talked down to at times. And like sometimes the medical appointments can just feel like just, I don't know. I don't mean this in like a bad way, but like just so like uptight and professional type of thing where it's like when they've been to a lot of different providers and they're frustrated and they don't know what to do. I personally feel like it's kind of refreshing to come into a medical appointment and, your providers kind of just chilling, hanging out, and just having a conversation with you. And it's not trying to make it some like too serious of a thing. But I do think like just talking to them as a person versus like someone in pain, but seeing them as a human being, I think is can go a long way. But anyways, all right, look at us already getting into it, talking about what we do to take care of these tough cases. So let's go on to like clinical decision making. So we had a patient, they presented super freaking weird, or you weren't sure what was going on, and kind of what we did to kind of break it down. All right. So this was one of my last evals I did at my last job at Gunderson, which I refuse to call them Amplify Health, by the way. I'm not going to call them Amplify Health. Screw that. It's such a dumb name. Anyways, one of my last vestibular evals there, he was a middle-aged man coming in. He has a history of lung cancer, and he comes in for dizziness. He just saw urgent care um, at Winona there, and it was for a same-day appointment. So the PA in the urgent care was like, "Hey, I have this guy. He's super dizzy, can barely walk. He's so dizzy. Like, I think he might have." I think she said, "I think he might have BPPV." I'm like, "All right, well, usually not the case, but I have an opening, send him on over." So he comes over, look at him, and kind of everything that I saw, I was like, the best thing that I could think about right now is I think you have vestibular neuritis. So I think he has an infection of his inner ear that's just making his cranial nerve 8 just go berserk and sending crazy signals to the brain. So he basically thinks he's on a nonstop roller coaster, and he feels like crap. Um, and then I put him in the goggles, and he had some pretty weird nystagmus patterns too. I can't even remember exactly what they were, but I know that they weren't fixed. And so when they're not fixed nystagmus patterns, you get concerned for, could this be of a central sign? And so
Central
um
meaning their brain.
yeah, so it's coming from their brain, not their peripheral, which would be the vestibular system. So I was kind of in between a rock and a hard place on it, because I did other central testing to try and like let's make sure this guy isn't having like a stroke or something, right? And all of his central testing cleared out, like coordination testing, rapid alternating movements, it all cleared out. I'm like, all right, his nystagmus is weird, but his all of his other central testing, I'm not like concerned about. At the end of the day, I was like, I'm sending you back to urgent care. Like, I'm sorry. Like, but I don't think, I'm like, you're not fit for like vestibular PT right now. Like, your symptoms are just off the charts. I was like, here's some different things you could try in terms of like grounding strategies so you can try and, minimize your symptoms, etc. But I was basically like, I don't think while you're non-compensated at this point, PT is going to do a whole lot. And I was like, you definitely don't have BBB. We don't have to worry about that. And before I sent him back to urgent care, I actually went and talked to my colleague, my mentor at the time for vestibular care, and talked to her about it. And we were kind of in the same boat of like, yeah, let's send him back to urgent care because at the best, it's vestibular neuritis, and he can get a steroid taper and take care of it. At worst, there's something going on centrally, and he needs more additional workup. So it felt like the best decision to do. So send him back, and they ended up he went back and he saw a different provider. This time he saw an MD, not a PA, and the MD was like, screw it, just you're getting imaging. You're like, we're not gonna mess around with this. Just we're gonna image you. And the one thing I kick myself on is knowing the history of lung cancer and where it can metastasize to. Came back, he had a 4 centimeter tumor in his cerebellum. Like, I know it doesn't sound like a lot, but like that's a pretty big tumor. And I hope I'm not misremembering the length of it. But anyways, don't quote me on it. It was a big tumor. Like, you looked at it on the imaging, like the actual image, and you scroll through and you're like, that thing is taking up a lot of freaking room in that brain. So then thankfully he got rushed down to the main clinic in La Crosse. The on-call neurosurgeon did a removal of the tumor like that evening, and it came back as there was a metastasis from the lung cancer. But then I never saw him again. But from last I heard, this individual did some treatment for it, and before I left, what I knew was he was doing pretty good, all things considered. So that was probably one of the harder ones I've had to do. Thank goodness for colleagues, because I feel like in those situations, and Christian, you can probably back me up on this, when there's something crazy going on, you kind of think to yourself, like, what are the odds of this actually being here, right? What are the odds that this guy has a tumor in his cerebellum? And you don't want to be that clinician that like overreacts, like, you need to go to the ER right now because you have a brain tumor. Like that, I feel like you don't want to be that guy. But in this case, it's like, dang, I think we have to be that guy, or at least send them back there. So I was very thankful for my colleague at the time because I was able to voice what I thought, and she was very reassuring in that, like, no, this sounds like what you're thinking, and you know, we should just send them back. So yeah. Anyways, that was my kind of really tough situation in the last couple of months.
I think you did a great job. Obviously, you did the
Thank
right
you.
thing, all things considered, looking in hindsight. But your story, highlights probably the most important thing that we do in healthcare, which is we are always weighing the odds. What are the chances you have this really bad thing versus this not so bad thing that's going to be just fine over time? And
Mm-hmm.
all human beings, every single day of our lives in our normal everyday life, we are weighing odds, whether we know it or not, to guide our decisions. And in healthcare, I'm trying to weigh your odds for you. And I have to always be sure that I'm accounting for what's more likely, what's less likely, given your presentation, what sort of little factors add on or tweak or add nuance to that decision.
Mm-hmm.
And almost all the time, we are looking at horses, not zebras. That, like, you very rarely will have someone that actually has a super scary thing going on that you have to address immediately or refer out. Almost every time, it's the less bad thing.
Mm-hmm. Yeah. Yep.
And even as the clinician, knowing that when you know it's probably not cancer in their cerebellum, it's probably vestibular neuritis, like 9 times out of 10, if not more than that, that's what it is.
Mm-hmm.
You still have to be like, okay, but always remember your ABCs, which is always believe cancer. Anytime someone has cancer in their history,
Yeah.
you have
Yep.
to, as a rule in healthcare, think that it's cancer. And I've had patients actually get pissed off with me when I've said this. Not too many. It's only
Yeah.
happened a handful of times, probably like 2 or 3, where like they say they have cancer. They're like, yeah, but it's not a thing anymore. It's not cancer. And I'm like, look, I have to be thinking about this for you because this could be what it is. I know that you don't want to hear it because maybe it's, kind of like traumatizing for you to reflect on that or have that be a possibility, or whatever
Yep.
other reason you might have. But like, there's a reason we have ABC. It's because it can happen and it will happen and it will go missed. And it can go missed for a long time. And I don't want to be the
Yeah.
guy that's missing it. So whenever someone has a cancer history, I definitely am more quick to jump the gun and be like, we're going to refer back to the doctor. Like, let's not give this that
Yeah.
much time. If anything is weird about that, I'm certainly going to be referring. But if there's not cancer in your history, I'm almost assuredly going to move forward with treatment and just know that it's probably not going to be anything sinister or scary and you're going to be totally fine. But that's not always the most comfortable thing for the patient because the patient, they're the ones living with this. They're the ones who can't be very objective about this. And anytime you go Google stuff, you're going to find like, oh, this is probably something really scary. I know
Mm-hmm.
that happens to me when I do my own Googling for my own lab blood work or whatever. And so I get where folks are coming from with wanting to take things really seriously. But at the end of the day, most of the time it's just not serious. And like we have to be comfortable as clinicians making that decision for you. And hopefully doing our very best to articulate our rationale for why we're not sending you to the emergency room.
Yeah.
You probably don't have anything crazy going on.
Right. Yeah. No, I mean, those are all really good points. And I think that's the big thing is just being transparent with them and being like, hey, this is what I found. This is what we found today. Um, here's the likelihood of it being something bad, or here's the likelihood of just having this be the thing, right? Just so that they know where you're at. And I think another thing that in tough situations, I like to do is like just be super transparent and like humble with them about it. Like I try not to be like, I guarantee you that this is what's going on. It's like I always try and let them know, hey, here's the test. Here's what you came with. It sounds like this. It could be this, but also the human body's weird and our tests aren't perfect. Not every diagnosis is going to line up perfectly with a subjective report. Like something could be leading us astray right now, and for that reason, we're going to err on the side of caution. But just not having like an ego about it type of thing and not, letting that get in the way and just be transparent, honest with the patient about where you're at and what you think.
Absolutely. No, I think you did a really good job. That was, I think you told me about that case probably
Yeah.
a month ago or so. And yeah, I
hmm
think you did everything right that you possibly could in that moment.
Thank you. I appreciate it. Well, I'm excited to hear what you got going on, Christian. What's coming up your alley?
Well, I think one of the more tough decisions or even conversations that I have to have in the clinic often are around low back pain.
Yeah.
So this one, it happens almost every day, I'd say, where low back pain, kind of like you said, the human body is weird. Low back pain refers pain all over the freaking place. And when I say refer, I mean like you might have pain in your back, but also in your leg or your foot, or you might have shooting nerve pain, which is a different kind of pain, not referred pain. It's going to be more radicular pain
Mm-hmm.
that can be in the thigh or the knee or the foot as well. It's just like these, it can be all over the place, and you can have serious reasons for low back pain and non-serious reasons, and you can have reasons that are not serious but probably won't really go away because you're 70 and that's just the way it's going to be, and no matter what we do, it's probably going to be there a bit, but we're still going to try. And so like
Mm-hmm.
trying to have those tough conversations around, this is what I think is going on, this is what's going to have to happen for you to try to get better. No guarantee it will. Most of the time you do get better. We also talk about the imaging around this and what that might mean, but just helping people understand, like, once you have low back pain, there's no guarantee you're not going to have it again. You probably will. And then I don't
Yeah.
know how long it's going to take for it to get better. And I don't know what degree it's going to improve. I don't know exactly what treatments you're going to need for it to get better and to whatever that unknown degree is, but I have a general idea of what needs to happen. Like that kind of language, that's the real truth about handling, I would say, most conditions that we deal with, but specifically around low back pain. And
Mm-hmm.
people just don't like that. They don't like the uncertainty. They're like, well, what if we get a scan? What if we got an MRI? Or like, what if we got a CT? Or I just need an X-ray. I need to know what's going on. It's like, sure, maybe we can do that and it might help, but chances are it will not do anything to help you. In fact, it's just going to make things even muddier. And that's just very tough for people to hear. And it's tough as a clinician to try to discourage people from spending tons and tons more money on this stuff that they probably don't need. And I know that we've talked about this in many different podcasts around just the nature of healthcare waste and making sure patients are heard and you're not just like telling them no to be mean. It's like, no, this is the reason why we're not doing it. And then also the big thing that comes up with folks that have these different cases of low back pain are that the doctors don't know either. Like, for example, I have a patient right now who was referred to me for their diagnosis was greater trochanteric bursitis, or just the side of their hip hurts, their butt hurts. Gluteal tendinopathy is a common
Yeah.
reason for why the side of your butt hurts. And this lady can hardly walk. It hurts so freaking bad. And her back hurts a little bit, but not that much. But most of the pain's in her butt and the side of her butt. And, you know, at first glance, it seemed like it probably was her hip, but I wasn't convinced of that. I was like, it
Mm-hmm.
could be from your low back too, but I don't have any imaging to support this. And so I treat her for like a session or two, and she's just getting worse. She's just miserable and not
Yeah.
getting any better whatsoever. Then I'm like, you know what? Let me just pivot our treatment to the low back. Let me just, I know the doctor told you it's this. I know you believe them more than me right now, but I think that this might be your low back. I'm going to treat your hip the whole time. Don't forget that. Don't worry. But I also want to try to add
Mm-hmm.
some for your back. And, you know, I did a session of like deep tissue work and joint work, more hands-on techniques, didn't really do anything. So I'm like, oh, okay, maybe
Mm-hmm.
this isn't going to be part of it. But then I'm like, you know what? Let me just do one more thing, because I was pretty certain the back had a role in this. And so I actually got her on the mechanical traction table, which I know a lot of people hate. A lot of doctors and physical therapists just don't like it because the evidence around it is a little mixed. But
Mm-hmm.
it seemed like the most appropriate thing to do for her in that moment. And the day after traction, I got a message from her saying, my leg pain's gone. I feel so much better. And it lasted for days. And so I saw her a week later. She's like, I still feel so much better after that. Can we do that again? I'm like, yeah, absolutely. I don't care. Let's do that again. And
Yeah.
now I'm pretty damn certain that her back is part of her pain. And I guess I'm sharing this story because it highlights the difficulties that we can have in healthcare, where we got to go against doctors. We got to have these people that are in a lot of pain. We might have mixed ideas around what's going on, what we should be doing to help them. But at the end of the day, you got to just keep moving forward. You got to act and do the best you can to highlight your rationale for them and check your biases every step of the way.
Yeah. Yep. No, I would agree, man. What I really like, what I really liked about what you're talking about there is, that idea of branching out a little bit. Like don't get me wrong. When I see someone, especially if it's low back, you know, I I try and do what the evidence says to do first, right? Versus going shooting for the stars on some modality or something that has little to no evidence with it. But like after you tried several sessions of things that you know surround what should give her the best shot of getting better, it's like, you know what? Yeah, maybe this thing doesn't have the best evidence to it. Maybe this is just going to be placebo effect. I don't know. But at this point where we're sitting, the hands that were dealt, it's worth a shot giving it a try, right? So I really like that part. And the other part I really liked is the idea of when you talk to patients about low back pain and you just give them the statistics. It's like, hey, don't be pissed at me. I didn't write up the statistics. Stats are stats. But the likelihood is that you're going to be having recurrent back pain episodes for, you know, years to come. That's just the stats of it. And I think it's this idea of not over promising, or at least not trying to be like bigger than the diagnosis and being that person who's going to be like, I can promise you, if you stick with me, you'll have no more back pain for the rest of your life. That's a big, that's a big promise that you just made, right? Because I feel like you all like, you see those people all the time online where they put out these crazy ass posts about how they can eliminate your pain and wherever it is, like guaranteed. And it's like, that's a very big thing to say. And as a clinician, when you're sitting one on one with a patient and you say that, and if you don't deliver that, you just all the not maybe not all the credibility, but your credibility went several notches down if you're going to promise something like that and then not deliver on it. At least in my opinion. So I really like how you kind of set the stage and the expectations with the patient population around low back pain and, you know, make it so that's not something you're over promising.
Yeah, I mean, that goes into a whole different topic around when is it okay to make promises to people? When is it okay to do things with the patient or for the patient that you know are not that potentially useful, or, you know, it's a mixed bag, but you're doing it more because you need this person to buy into your plan. And to me, that's sort of a tough decision in itself, because if you don't make that promise to that patient, someone else will. Maybe it's going to be a different PT locally. Maybe it's going to be some guru on the internet. Maybe it's a chiropractor locally, or their doctor, or a specialist physician, which, trust me, I hear this all the time. Surgeons make way too many promises. Certain pain doctors in our area make just egregious, outrageous promises. People want that. People want that confidence. They want that certainty. In my view, sometimes you got to play the game a little bit. Maybe
Mm-hmm.
that's a hot take, but when I have a patient who I feel needs to be on a certain plan of care, not because like I think I have the best plan, but because like I know how this generally plays out. I've seen this happen hundreds of times. If they do these kinds of things, they're going to get better to some degree. It's just a matter of time, but they're in it for that quick fix, or they don't buy into that plan with me yet. And I know that if I don't do something, I'm going to lose them, and they're not actually going to get better, or they're going to go do something totally silly that's going to lead to
Mm-hmm.
many, many more months of an issue. Sometimes you got to get your hands dirty and be like, you know what? Like, I'm actually really confident about this plan. I think that this is going to work for you. Of course, you're going to lay out your rationale, but in a sense, you want to make sure that they feel like you got their back, that your plan is going to work. You have some level of certainty, because that's what they're seeking. And if you can't provide that, they're going to find it elsewhere. And oftentimes they're going to go searching and not find it at all. And then
Mm-hmm.
that small concession you made in your just like, I guess, complete honesty ended up being a net negative for that patient. This is actually
Mm-hmm.
something I'm going to be bringing up in this month's journal club with my colleagues at my full-time job, where it's my turn to pick the article, and I'm going to pick an article that talks about when should we, or even if we should, do things that the patient likes or the patient wants, instead of just what the patient might need in that moment, because you need to
Mm-hmm.
win the battle of getting them to perform to their fullest, a sensible, solid plan of care.
Yeah, that's a really good point. Um, And I think there's a difference between being transparent, explaining your clinical rationale, being confident in what you're going to have someone do. I think over promising. I think that, and this is just my opinion, hot takes, a lot of hot takes this morning. If you're out there with a certain type of pain and like and you see someone online, or if you meet someone in person, a chiropractor, PT, a pain medicine doctor, whoever it is, and they say, you know, oh, I can get your pain to go away in these however many steps, or like, I promise that we can, take care of this in 6 weeks, whatever it is, you know, like, push them a little bit. Ask them for, well, what's your rationale behind it? Like, why do you think this is going to work? Like, what's the science behind it? Like, push for those different things. And, I think a lot of people, you can kind of tell if someone actually knows what they're talking about in terms of they have the confidence and the rationale behind why they think they're going to get you better, or if this is something that they kind of gleaned off the internet or they kind of came up with and they're not 100% sure how it's going to get you better, but it's just, it should, or however they want to put it. I think kind of pushing into your clinicians a little bit, or whoever it is, and just ask them, you know, why do you think this is going to get me better? Why would you do this? What's the research behind it, etc. So yeah, definitely, I think that there's a difference between the confidence, rationale, transparency, and just like kind of blatantly over promising to try and buy people in. And maybe that's kind of what you're getting at there, Christian, in which case I think that's going to be a great article to discuss amongst you and your colleagues.
Yeah, and that is what I'm getting at. Just when it's appropriate to do what the patient wants, as opposed to giving
Yeah.
them just all of what they need. And I think
Yeah.
it's a gray area, but I care about being effective. I care about winning. And if that's what I have to do some of the time, I'm going to do it because I think that is part of making solid clinical decision making
Hmm.
because it ultimately will be the best for the patient. But thinking about those tough cases, we've been talking a lot about just different thoughts around clinical decision making, which is a whole topic in and of itself. And I think we've talked a lot about how we like to approach these problems. But something I think really works well for me when it comes to having quick but also fairly accurate clinical decision making, and like when I have a tough patient, what do I need to get into? I use a lot of heuristics or rules of thumb in my practice. And I
Mm.
think you do too. I don't know if you are familiar with that term,
My
but that's
vocab
something
in
I use.
English is pretty limited, so.
Yeah, so heuristics are mental shortcuts or rules of thumb that allow for quick and efficient problem solving and decision making.
Perfect.
Yeah, so like
I do
in
this. Yeah, you're right.
in you know what this is. In physical therapy school on day 1, every one of your teachers and really any mentor you have after is always going to tell you that physical therapy is an art and a science. And whenever you ask a clinical question to one of these professors or mentors, they're going to tell you the cop out answer is always, it depends. And I am a very literal person. And so this type of response has just never sat well with me. It's like, okay, sure, I know it depends, but what does it depend upon? What exactly went through your head for you to make that decision that you made? How did you rank the importance of that information? How did you decide the most proper course of action in the face of crippling indecision, which we all feel very early on in our careers? And uh, this is where the concept of heuristics is vitally important because whenever you can create these rules of thumb for how to conduct yourself and how to help a patient get better, you are taking that big, broad amount of information that you're going to find from your teachings and your readings and your extra coursework that you do and your own lived experience, and you're distilling it down into its most raw form. It's like the Richard Feynman thing. If you can't explain it to a 6-year-old, you don't understand it yourself. So if you
Mm.
don't break down those bigger concepts into smaller tidbits or gems, the big picture is going to get lost and you really can't act quickly for your patients. And that's going to lead to you having a harder time dealing with those tougher patients on the fly in that moment in real time with them being like, I need help, buddy. Like, let's do something here. But
Uh-huh.
Eric, like, do you ever think about heuristics? And we can go through a bunch of examples that I wrote down if you'd like in a bit.
Um, yeah, I feel like I use these the most when I'm trying to transition from like the eval portion when I first meet someone, right? From the eval portion, like the treatment portion. Those different mental shortcuts that you might have that you kind of gain the more you see people in terms of, oh, this person's presenting with this type of pain, or they're presenting with this type of, functional loss. And you kind of pick up ideas of this is where I want to start with treatment. And it's different with everyone. That's the thing is this isn't a cookie cutter approach, right? We don't use heuristics to, put people into boxes and then give those people in that box all the same stuff. Because you still have to take into account the patient's, you know, what's their, who are they? What's their personality? What is their irritability level? What's the timeline in terms of the chronicity? Is this a chronic thing? Is it an acute thing, etc.? So although you might have the same functional loss, the same diagnosis that you're suspecting, the same body parts, etc., you still have to take into account all these other things that's going to make your treatment style individualized to this one person. But definitely using kind of those mental shortcuts when it comes to, okay, patients presenting with these things, we're going to get them started on these one or two things and then blow it up to get them back to where they want to be. At least that's how I like to think about using when I think back on using kind of these heuristic type things in my own practice that transition from the evaluation to the treatment.
Yeah, exactly. They help you sift through all that noise and be able to act quickly in a moment when you're maybe short on time. But also, healthcare, medicine, physical therapy, it's imperfect. We can't know everything all the time. At some point, you just have to go. And that's what I try to tell people too is like, I know that you're hurting. I know that this whatever approach isn't working that well, or you've tried this. Now we're gonna do this new thing with you. That's part of the process. Like I don't have all the answers on day one. Sometimes I do, but most of the
Mm-hmm.
time I know enough to get started, and I'm going to learn more as you go because I can't write a plan for you from start to finish, day 1 to month 6 for your tennis elbow or your low back pain. There is so much that I don't know based on your response to our initial plan, what's going to change, how stubborn this thing is, whatever else is happening. There's way, way too many variables. And
Yeah.
that's why I like the engineering method versus the scientific method. I don't know if you have ever heard of the engineering method, Eric.
No, I'm trying to think of it. I can't.
Yeah. So everyone knows a scientific method. Its definition would be like a systematic approach to gaining knowledge that involves making observations, forming a hypothesis, testing it through experimentation, analyzing the results, and drawing conclusions. Who has time for that in real life with a person in front of you? You don't. It's impossible. You can't just do a study right then and there. So
No.
this is where the engineering method is really helpful at creating an actionable plan. And it's just like a fancy way of describing what a heuristic is. So
Mm-hmm.
a really good definition of the engineering method is going to be solving problems using rules of thumb in a poorly understood situation using best available evidence and resources. And so I have this person in front of me. They're in a lot of pain, whatever the problem is. I don't know exactly what needs to happen, but I know given their age, given how long this issue's been going on, given how irritable or severe it is, given what they just did the last couple weeks, given what they have coming up in the next couple weeks or a month, whatever else I'm thinking about in that moment, I'm just like getting these little snippets of, okay, do this, don't do that, definitely do this thing, try that. I get all these different rules of thumb and considerations in place, and those are just like mixing in
Mm-hmm.
my brain. And then I put those together into an output of we're gonna do this.
Yeah.
Is it perfect? Is it correct? No. But based on the quality of those rules of thumb, I can use that engineering method to get a really, really good answer quickly. And then I can just edit that answer over time because, again, this is physical therapy and they're not bleeding out on my table. So I have the luxury of some time here.
Yeah, yeah. No, it's a really good point that you bring up there. You have some luxury of time there to figure stuff out, and that's a good. I want to go back to your initial plan and not being able to necessarily write that their entire plan off of the first visit. And part of that is also just due to time constraints, right? Like we only have so much time with you, and we like to talk, we like to get to know you, we like to make sure that you feel heard. All these other things, like that's part of it. But another part of it too is, we might do a certain amount of tests and measures and whatnot. And we look up at the clock and it's like, we have 10 minutes left. I want to get you on a plan. I want to get you going. There's still some other things that we can maybe look at, but that might have to be for a different time. And then the other thing I want to say is the reason why I don't think, unless it's an acute thing, unless it's like I sprained my ankle yesterday, here I am, and you're a healthy 20-year-old college student, right? Um, in which case, all right, I might be able to get pretty close to giving you the whole plan right now because this is a more predictable thing, right? It's probably going to go how we think it's going to go versus your, you know, 50, 60-year-old individual that's had shoulder pain for the last 25 years. And it's like, well, this onion's got a lot of layers and we're going to start peeling them back. But as we peel back, we're going to change based on what your body is telling us, the direction that we need to go. So yeah, I mean, it's kind of like you said, like it's great to get them on that initial plan, but it almost always it's going to change because almost everyone we see is going to have usually some type of chronicity to their diagnosis. I love it when we get acute things, but unfortunately, that's not always the case.
Absolutely. So for these tougher cases, especially if you're kind of getting in the weeds with the conversation piece, like they have a whole life story to tell you, and they also tell
Yep.
you more and more stuff every time you see them. You don't have time to just like write down all your thoughts and process all the information at length. You have to just go. You have to act quickly. And also these heuristics I find are really useful for when something isn't going well. How do you pivot? And then can you pivot very
Mm,
quickly in that moment? So for example, people might be doing really well on your initial plan for 3, 4 weeks or it's going okay and you're letting it play out. But then you're like, you know what? They're getting subpar results. I think they could be doing better. Or this was working and now it's not. And now we might need to pivot. How do you pivot? Where do you go? You just found out the person's not doing well in the first minute of your conversation. Now you got to spend the rest of your session doing something totally different because they're flared up or you're going to change your plan. This is where heuristics really come in handy. So you know how to proceed, how to change something on the fly for this person in this tough moment. And I'm just going to give you some examples of heuristics, and
mm.
these can be literally anything. They're all rules of thumb. These are just ones that I've developed over time that I thought about within 5 minutes. I bet I could write a book on this. Maybe we should. That'd be kind of nice. But
Heuristics of physical therapy.
totally, and this, yeah,
Nailed
side
it.
project there, side project. Yeah,
As
so
if
like
we
here are
don't
some
have enough
examples
stuff
that
going on.
this is stuff that's going on in my brain when I'm with you in the moment. Here's one. So if your pain increases during your activity above a 2 to 3 out of 10, stop. Don't push through it. So most of the time, trying to push through a bunch of pain, regardless of your irritability level, it's just not worth it most of the time. Yes, you can get better by pushing through pain. We have research to support that. This is kind of the long answer now. It's beyond the heuristic. And sometimes you have to do that, but by and large, it's not worth it. The juice ain't worth the squeeze. It's just don't
Juice ain't
do it.
worth the squeeze.
Juice ain't worth the squeeze. Move on.
Yep.
Just chill out. Um, Whenever possible, train through a full range of motion. That's just a simple rule of thumb that I have in my head at all times. And generally speaking, more range of motion is better for hypertrophy. It's better for your strength. It's better for building endurance through more of a range of motion. It's usually better for desensitizing a painful area. Let's say you're not even trying to go for strength or endurance. I just need
Mm-hmm.
you to learn that this movement isn't so bad to do anymore. I'm not going to accomplish that nearly as well most of the time by having you do partial reps. I need you training that squat through as much range of motion as you can. Teach yourself that, oh, wow, I guess I can actually do this. And when in doubt, do that. Another one that I think is really useful is strength is almost always better than endurance, power, or hypertrophy for pain
You're
and
gonna
injury prevention.
catch some hate for that one.
Dude, this is a rule of thumb. I'm telling you. And this just comes from me reading about injury prevention just ad nauseum and then learning about strength and conditioning principles over like the last 9 years and just doing this day in, day out.
Sure. Yeah.
When
Yeah.
in doubt, train strength. Just get someone stronger. Good things are going to happen. Whether or not they actually had to get stronger or you could somehow measure that they were weak, whatever the hell that means, just getting stronger, lifting more weight. And I don't mean doing tons more reps. Yes, I know you can get stronger doing that too, but I literally mean adding more resistance on the bar or bigger
Yep.
dumbbells in your hand, going to a harder band. That is a fantastic rule of thumb that I think is super, super useful. Then one last one I'll leave you with is going to be more my training clients. It's don't train high volume specific exercises during the athlete's competitive season or even just before it, like the first month before it. A common one that I'll get here in Maine are going to be hikers. Hikers
Mm-hmm.
that all winter, I don't know what the hell they did. They didn't do shit. But then come spring and come summer, they want to get back on the trail and they're like just jumping out doing the Appalachian Trail hikes at 5 miles. And they're like, oh, now my knees hurt. Um, Maybe I should do more step ups and lunges and I'm going to hike twice a week now. It's like, well, hold on. You, you're weak, you're deconditioned, and now you're just going to go hit hiking 2 to 3 times a week on very, very hard New England terrain that is entirely comprised of step ups and step downs. And then on top of that, you want to go hit the gym twice a week now and do more step ups and step downs. Maybe we do movements that aren't quite the same as hiking because you're probably going to overuse that movement pattern and it's just going to feed into you getting hurt more and more. And so if I have the time and I have a client who wants to do this before hiking season begins, we train those movements like step up, step downs. During the season, we do other things like double leg movements or more posterior chain based things because their knees are going to be fried from the hiking itself. But these are just some simple heuristics, rules of thumb. There are many more, but these are simple shortcuts that I use to guide my clinical practice, and it works really well most of the time.
There you go. No, I love it, dude. Those are some great ones to have in your back pocket. And yeah, man, I think I really like the strength, not just to get stronger, but to do things like desensitization and to try and just build confidence and show the body, show the person that they can do more than what maybe they think. But no, I think all those different examples that you gave are fantastic, and I think a lot of them can be used for both, rehabilitation and also strength and conditioning. Like I think they kind of go hand in hand for a lot of them. But yeah, yeah. Do they not go snowshoeing in the wintertime? What are they doing in the wintertime? These hikers that are leaving them so deconditioned come spring, summer.
Or skiing.
Not even like Nordic skiing probably. They're probably doing the downhill
No,
skiing.
they're downhill skiing. So there's like very, very minimal eccentric force through large range of motion, which is what hiking is. And
Yeah,
so they're like, yeah, I was active all winter. I'm like, I know, but like, it doesn't count. I'm sorry. It like counts for a little bit.
it's not the same.
That's why you should be doing strength training because it
Yeah,
counts for a
yeah,
lot
yeah.
more.
That's true. That's true. No, dude. Very cool. Yeah. Thanks for giving us those different examples there that you use. I think those are all great and good tidbits for individuals to take with them as well. But no, man. Speaking of strength training, I got a I got a new squat rack in. I don't know if I told you this. I bought a
Not the
new
new
squat.
rack yet. Oh, you
I
did?
bought
Okay.
I bought the new squat rack that we talked about. So for like the first couple weeks in the home gym, I was using like this kind of older, shoddier squat rack I bought for like $60 off of Facebook Marketplace. And like it was getting the job done. It was doing its thing. But I soon realized if I want to take this home gym seriously and do everything I want to do, I'm gonna have to get a legit squat rack. So I spent some extra money, paid a little more, got an actual squat rack that is sitting in the box in the garage right now. I got to put together, and then I got a new adjustable bench to go along with it as well. So I'm excited, dude. It's like Christmas morning, man. Open up these boxes and putting together a squat rack. I'm pumped.
Dude, it's adult Legos.
I love it. I love it. But
I'm trying to figure out how that applies to making tough decisions for patients. I don't think
well,
it does, but it was
I
a
just figured that was a
nice
good that
tangent.
was a good that was a good lead out. As we're coming to the end of the podcast here, figured that'd be a good little send off. But yeah, I guess that's a good one for patients. If you ever need to make a tough decision, 99% of your tough decisions as a patient or a clinician can be solved if you just have a home.
Really is true. That's a massive barrier to people getting better. Is like, I'm like, where do you want to do your exercise? They're like, at home. Like, what do you have? Nothing. Well,
Shoot.
okay. All right. We'll
Yep.
figure it out.
Yep.
I guess the last thing I wanted to say for making these tough decisions, we already talked about general stuff around our clinical decision making process. We talked about how we use heuristics or rules of thumb to guide your initial treatment, but also how we might pivot in the event that something just isn't going our way. But the last one that I use, I'm sure you use all the time too, is refer. If
Mm-hmm.
it's a hard case, dude, when in doubt, refer out. That's a heuristic
Absolutely.
right there.
Yeah.
If you are unsure about what's going on, or the patient just, you get the sense the patient wants a little bit more attention from whether it's someone else more laterally or it's going to be someone more vertically, like a surgeon or a sports med doctor, just refer them. I don't, I don't know where you stand with this, but like there are some PTs that I don't know who they are, but I hear them on podcasts or on videos or I read about them on the physical therapy subreddit
Who
or
are
some
these
other
people?
blog that might read. I know they're just like, they just sound so matter of fact. Like, yeah, well, I just tell my patient, this is what's going on. This is what you're going to do. You don't need a doctor. It's not going to help you. And I'm like, yeah, great. But like, how would you feel if you felt dissatisfied with the service and you wanted to do something different for it
Mm-hmm.
and someone is telling you no? Like, that kind of sucks to hear. So I am much more open and more sensitive to referring people to their doctor for maybe less than some other therapists might want to refer for, just because I'm trying to take my ego out of it and make sure that that patient is getting the health care that they want to pay for, that they need or not
100%.
need. And like, is that referral just dismantling our healthcare system if it's a bit excessive or egregious? Not usually. I'm not trying to make a habit of this, referring out for minor things, but I will still do it. Of course, I'm going to refer for major things if I feel like I don't know what's going on. Go to the doctor,
Yeah.
please. But
Yeah.
yeah, where do you stand with this?
Dude, that's a heuristic. God, this is my new favorite term, I think. Learning so much. I always tell my patients, they'll ask me like, should I go to the chiropractor for this? My son or daughter sent me this thing on Facebook about some holistic supplement that's supposed to help joint pain, right? And they're like, what do you think? And I'll be like, I don't know S about this holistic supplement, but if you feel like it's worth your money or going to the chiropractor is worth your time, if you feel like something is worth your time and money, do it. Assuming it's not going to harm you, do it. You should do it. If you feel like it's worth your time and money because it's helping you out or you like it, whatever it is, go for it. On the flip side of that, if you don't think it's worth your time and money, and I'll even tell them on the eval, if you don't feel like I'm worth your time and money, I will not be offended if you tell me that you want to go a different direction. I will try and find that best direction for you. But time, money, if it's worth it, not worth it, do it, don't do it. But in terms of not referring out, no, I refer out definitely for the big things, but even for small things, or just reach out, right? Reach out to a colleague, reach out to the doctor, to the sports PA or someone, and just get their take on it. Like, hey, I have something tough going on with a patient. Can I pick your brain a little bit, right? So yeah, I definitely do that, and I just, yeah, take the ego out of it. Don't let yourself get in the way, because the thing, that's what I was gonna add. That I was gonna finish with this. Think about, like, if you were going to a mechanic and you had something weird going on with your car, and the mechanic charged you $500 for a fix, and it didn't do anything, or maybe made it worse, and you went back to that mechanic, and the mechanic goes, don't go to another mechanic, or don't go to a more specialized mechanic. Just stay with me. I know what to do. I know how to fix this. And then, are you still going to feel comfortable paying that mechanic another 500 for every time you have to go and get something fixed? It's like the same thing with PT or chiropractor care, or, a personal trainer, or even a medical doctor. Like, just because it's medicine doesn't mean it's really any different than getting your car fixed. If you feel like someone's just trying to keep you there because they have a big ego and they don't want you to be helped by someone else, or they just want your money, you know, go find a new mechanic, go find a new PT, go find a new whatever. Um, yeah, yeah, that's something that kind of does get me revved up a little bit, is when people let their egos get in the way, and they you know can't reach out, can't refer out, can't do that. I got to do it on my own. We'll figure it out. It's like, dude, you're just hurting the patient, man. Just swallow the pride a little bit, get them what they need. But
Yeah. And also sometimes you're just not going to get that patient better. Like it's
yeah,
just the longer you're in the profession, the more that you recognize you're going to lose. Losing is part of any profession, especially one that
yep,
deals with people in pain. It's just you cannot help everyone
nope,
for whatever reason, whether it's their condition or they don't like your face, or you just chose the wrong heuristics to get started and that person got flared up in their first or second session. Now they don't trust you. They don't want to pay you that $500. They want to go to someone who they think is better.
mm-hmm,
Are they wrong for doing that? Maybe. Like they probably would get better given if you had the chance to change or pivot your plan, but they're not going to give you that chance because they're making a cost benefit analysis and they're trying to cut their losses. And you have to just respect that as the healthcare professional, that they're making the best decision that they can make given the information that they have at hand, and better luck next time. And
better luck
hopefully
next
you
time.
will do them a good service by letting their doctor know that you tried X, Y, or Z. This
Mm-hmm,
is the outcome. This is why they're no longer coming to you. But here's what you know. Here's what you saw. And that's it. That's all you can do right now. The patient will figure it out from there, or the doctor will do something. I don't know. But yeah, you can't, as a physical therapist, you really can't take this stuff personally. And you need to be, in my view, pretty quick to refer out to a colleague, or even just if you work in a bigger clinic, be like, do you want to work with this other provider and talk about, of
mm-hmm.
course, like they're really, really good at this kind of thing that I think might work for you. How do you feel about seeing them? Or, going from a male to a female provider or vice versa. Those little things go a long way for a patient feeling heard and feeling like, okay, this person cares about me and not just them being right in this situation. Because at the end of the day, like I said earlier, I just want to be effective. I want to win. I want the patient to get better. And if I'm keeping them with me longer than I need to and just making them feel like I'm not the right person for whatever reason, I'm not helping anyone. I'm just hurting both of us. Just
Mm-hmm.
move on. Find someone else to work with.
Great things to talk about, and kind of the just giving an insight, background to what we do every day with every patient, trying to weigh the odds and figure out what's going to be best for them, and where they need to go, next steps, etc. And then boiling all that down within a matter of minutes in terms of creating a plan of care for that patient where you want to go. So definitely, I think there's more going on behind the scenes than what people might think when it comes to what we do as physical therapists. But hopefully this podcast kind of sheds a light on that and how we weigh out the odds and go forward with that.